Hi, my name is Chase O'Leary, and today I will be presenting a systematic assessment and corrective exercise strategy for femoral acetabular impingement in the lumbopelvic hip complex. So femoral acetabular impingement is a condition where abnormal contact occurs between the femoral head and the acetabulum, often leading to hip pain, reduced mobility, and compensations throughout the kinetic chain. So I did 3 assessments. The first one being the overhead squat assessment, as seen here, where from the sagittal view we can see that there is some anterior pelvic tilt and limited hip flexion in the squat. The second assessment that I did is the single leg squat assessment, which revealed knee valgus collapse and excessive hip internal rotation on that single leg. And then the third assessment I did was a Thomas test, which indicated tightness in the hip flexors. Overall, my client presented with an excessive lumbar curve during dynamic movement, decreased hip internal rotation, and overactive hip flexors and adductors, and underactive gluteal muscles. For these assessment findings, I interpreted that the client's hip joint was not moving efficiently, leading to compensatory strategies throughout the lumbar spine and pelvis. The primary issues involved overactivity in the hip flexors and adductors and underactivity in the glute medius and deep core stabilizers. And these dysfunctions increase the risk of further joint degeneration, movement inefficiency, and chronic pain if it's not addressed right away. And to address the overactive tissues, I first implemented self-myofascial release techniques and focused on 3 main areas: your TFL, tensor fascia lata, and the adductors and hip flexors, specifically the psoas and the rectus femoris. Using a foam roller, the client rolled each target area slowly, pausing on tender spots for approximately 30 to 60 seconds, and this inhibitory technique was used to reduce muscular tension and improve tissue extensibility. For my following inhibition, I did static stretching for my lengthening technique to the shortened tissues. These stretches included of a kneeling hip flexor stretch, holding for about 30 seconds on each side, focusing on the psoas. Next being a standing adductor stretch, targeting the inner thigh muscles, and a TFL stretch performed by standing in a crossbody position. And each stretch was performed slowly, emphasizing breathing control and postural alignment to maximize effectiveness. Once we improved the length of the tissues, I implemented positional isometrics and isolated strengthening to activate underactive muscles. So these exercises included a glute bridge hold, focusing on maintaining posterior pelvic tilt to reduce that or to almost correct that anterior pelvic tilt that she had at the beginning, and contracting the glutes for 5 seconds per rep, along with side-lying hip abductions with an emphasis on the glute med activation and keeping the hips stacked on top of each other, and the dead bug exercise where the client practiced engaging the deep core while maintaining a neutral spine and correct hip tilt. And these exercises reinforced neuromuscular control and improved stability at the hip and the pelvis. After isolated strengthening, we progressed into integrated dynamic movement exercises to restore functional movement patterns. These included lateral band walks to promote hip stability and gluteus medius endurance, along with step-ups to ensure proper knee alignment and single leg control, really focusing on not letting that knee cave in into knee valgus and really using those abductors to align the knee with the ankle and the hip. And then lastly, multiplanar lunges with core bracing, integrating hip, core, and ankle stability across multiple planes of movement. These exercises helped the client apply their newfound stability and mobility to more of more complex activities, preparing them for daily tasks and athletic performance. So in conclusion, the systematic assessment really revealed overactivity in the hip flexors and the TFL, reduced hip internal rotation, and an underactivity in the glutes and core. By following a corrective exercise strategy that began with inhibition, lengthening, and progressed to activation and integration, the client is able to improve hip mechanics. There will be reduced pain and enhance overall movement efficiency. And yeah, thank you so much for watching.